not to put you on the spot and ask you what those 6 questions are, but just directionally, what are the criteria for ED in terms of severity, frequency, and such?
Sure. So I think one of the easiest ways to look at it is to use a question called the SEP2 and the SEP3. So there's just 2 simple questions you have to ask the patient. Are you able to get an erection sufficient for penetration? It's either yes or no. And are you able to maintain that erection till orgasm? It's either yes or no. If they answer no to either one of those questions, they have ED.
Under any condition, even if it happens just once, or if it says, well, 8 times out of 9, I'm okay, but 1 time out of 9, I can't.
So then they had 1 episode of ED. So it's graded, right?
Yeah.
But by definition, if someone says I can, and the number 1 cause of ED typically is I can't maintain it. So that's the first sign. They say, doc, I can get it, but I can't maintain the erection. They're telling you I have venous leak, which is the first sign of some kind of erectile dysfunction.
To be clear, this is not confused with something I do hear quite a bit of from patients, which is I can get an erection, I can maintain an erection, I can't ejaculate.
We're going to talk about
that's a separate problem.
Yeah, yes, that's right.
So that's not ED.
Yeah.
Okay. So let's talk about the pathophysiology of this. Again, at the risk of sounding and demonstrating my ignorance, how much of this is physiologic, i.e. neurovascular? How much of this is psychological?
So the mnemonic I teach the medical students is VENT. What are the etiologies? Vascular, endocrine, neurologic, and trauma. And Peyronie's disease can be trauma as well. So vascular, endocrine, neurologic, trauma. Don't forget medications. We'll talk about those. Beta blockers, for example, antiandrogens, finasteride. There's a lot of medications that can impair erectile function. And then there's psychogenic ED. Now, psychogenic ED typically is in younger patients, right? It's not common that a young patient has organic ED, but they have psychogenic ED. And psychogenic ED is treated very differently than organic ED. And you want to ask them some questions. Are you able to get an erection with masturbation? If they say, yeah, no problem, that's psychogenic. They're telling you they have psychogenic ED. Do you get morning erections? Oh yeah, I get morning erections, but I have difficulty having sex. You're telling you have psychogenic ED. So you want to probe for that because psychogenic ED is treated with sex therapy. I use daily Cialis in these patients. It's very effective, I think. There's ways to treat that that's very different than organic ED.
Okay. So tell me a little bit more about what that means. So do you refer out to sex therapy? What are sex therapists doing in these situations? How are they helping people?
Sure. So sex therapy, I do use sex therapists, and I think they're very effective. The problem is that many men don't want to see a sex therapist. They say, I want the pill. That's typically. And if they do want to see a sex therapist, now it's getting a little bit easier because telehealth. So they can do televisits. And before they have to go into the sex therapist's office and they're a little bit more likely to use the telehealth. So, but what has been very effective for young patients is we will give them daily tadalafil. So when they take daily Cialis, what they'll notice is that their erections are starting to get better.
And you'll do this at 5 milligrams daily.
5 milligrams. Okay. Now, what's interesting is that when a young person or anyone has erectile dysfunction one time, we call it the vicious cycle. What happens is the next time they engage in sexual activity, they say to themselves, as they're having sex, I hope I don't lose my erection. And they will lose their erection, guaranteed, because they're so fixated.
It's sort of like in driving, we say, if you're trying to not drive off the track as you're exiting a corner, looking where you don't want to go is exactly where you're going to go.
Right. That's the same philosophy.
The car follows the eyes.
Same philosophy. So what happens is, and then when they engage it the next time they say, I can't believe it's happened 2 or 3 times. They
and then
spiral.
It's just a total vicious cycle.
So they get anxious. And they also undergo subconscious aversion. They start avoiding sex because they're scared it's going to happen. Their partner thinks they have a low libido. Is it really a low libido, or are they really anxious about getting an ED? So typically daily Cialis, when they engage in sexual activity, they start noticing, hey, things are working. Things are fine. It's okay. And then you can many times wean it off. But you just want to show them that everything's working great again. We use a lot of penile ultrasound in my office, and it helps me look at the peak systolic velocity and diastolic velocity. Many times getting an ultrasound and showing them that everything is perfect is therapeutic.
Let's talk. I want to come back to the penile ultrasound and to the gain, what's the gains?
Yeah, so that's different. So that's the ultrasound for diagnostic purposes. What I do in the office, we put an injection in the penis, induce an erection. The other ultrasound you're referring to is shockwave therapy to treat erectile dysfunction. There's 3 areas here. There's stem cells, PRP, and shockwave, and that's a treatment option.
And we'll come back to that in a second. But let's go back to this. Maybe just for folks, explain briefly how Cialis, Viagra work. What's the mechanism?
So the erections are caused or induced by the parasympathetic nerves, and you can get stimulation, ocular vision, hearing, sensory, any kind of sensory stimuli, or tactile can induce the nerves to secrete nitric oxide, which will then go to the endothelium. This is the key. The endothelium will secrete nitric oxide, which is really the on-off switch. Once the nitric oxide goes up, we get an increase in something called cyclic GMP. Cyclic GMP causes intracellular calcium to go down. It causes the dilation of the sinusoids and increases the blood vessel diameter, and the blood comes in. Now, there's a bad thing there. There's something called phosphodiesterase, and phosphodiesterase eats up the cyclic GMP, and therefore you will lose the erection. So how does Viagra, Cialis, Levitra work? It's a phosphodiesterase inhibitor. So it blocks phosphodiesterase, so you have more cyclic GMP, so you can keep the erection around. Now, there's 11 different phosphodiesterases in the body. So, for example, type 5 is in the penis, 6 is in the eye, 11 is in the back. So some of these medications have cross-reactivity with the other phosphodiesterases, so you get side effects. For example, Cialis has more side effects with phosphodiesterase type 11, so you may get more back pain. Viagra has more cross-reactivity with type 6, so you may get changes ocular vision. So ideally, you want one that only affects 5 and nothing else.
And is there one to date that does that?
Yes. In my opinion, the newest one, Avanafil, has the least cross-reactivity with the other phosphodiesterases. So I think it has less side effects. The only difference is that it is not generic yet, so it's expensive.
Much more expensive.
Yeah. So the generics now, you can, if you go to Cost Plus or Mark Cuban's, or you go to GoodRx, it is so cheap to get Cialis today, but Avanafil is still not generic.
I see. You want to tell people the story of how Viagra was developed?
So Viagra was developed to be before 1998, but it was developed to be a blood pressure medication to control the blood pressure. And they started noticing that everyone was getting, or cardiovascular medication, and everyone was getting erections in the trial. Right, and that's how they
everyone
found.
who got the Viagra as opposed to the placebo.
Yeah. Very interesting. Other drugs were the same way. You may have heard of the drug Addy. We use this to treat female sexual dysfunction, or flibanserin. That was used as a medication for depression. It was by Boehringer Ingelheim in Germany, and so they gave it to women for depression, and they noted these women wanted to have sex, and that's how we got the development of Addy.
Yeah. And my recollection is Viagra was not successful as a systemic reducer of blood pressure. In other words, that trial failed.
Right.
And what I read, I don't know if it's true, but what I read was the trial failed. It was Pfizer, I believe, that had developed the drug. Yeah. So as their kind of tail is between their legs and they're saying, well, that sucks. We just lost all this money on a drug that doesn't treat blood pressure. But what they noticed was a difference in the samples being returned. So the patients who were on the placebo were very happy to send their samples back. Yeah. And somehow the majority of patients on the treatment drug, Viagra, which wasn't called Viagra at the time, of course, were disproportionately keeping it, which then prompted them to ask follow-up questions and say, why are you keeping it? Right. And that's how they sort of backed into this unintended consequence, which is amazing in that it went from, a ho-hum blood pressure drug that would have had a market size of this to a market size of this.
And it was a game changer in my field. So in our field, sexual medicines, I'm part of the sexual medicine side in North America, game changer in the way we treat men for ED.
And really, we'll come back to this, I suppose, but we'll put a pin in it. There isn't probably a single drug that has had that effect on women's sexual health, is there?
The first drug that ever came out was in 2015 called Addy.
Yep.
The second drug was called Vyleesi, but not even close to the impact that Viagra had in men. Both are excellent drugs.
They're more about desire.
They're more about desire.
Yep.
And we are learning that they may have some other functions as well, off-label, like orgasmic function. Both are good drugs, but they just really never took off like Viagra.
Yeah, it might be that the single most potent agent for women's sexual health, at least as a woman is aging, is actually HRT. It's probably that estrogen has the greatest single impact.
But there is a synergistic effect.
Yeah.
Because if you use HRT and you use these medications, because it's a different mechanism of action.
That's right. They're accretive in their...
Yes.
Yeah. Okay, so this phosphodiesterase inhibitor, which now we're into our third generation of them, basically solve a physiologic problem.
Right.
So... what is at the root of that problem? I understand that by inhibiting phosphodiesterase, you keep around more cyclic GMP, you maintain the flow of blood in the smooth muscle. But what is it about the aging process and or its comorbidities that is leading to that venous leak in the first place.
Right. So you nailed it. So the main issue is venous leak, or we call veno-occlusive dysfunction. So you have to think of the anatomy. So it's actually very clever how the system was designed. So if you think of the two tubes I was talking about earlier, inside those two tubes are muscle and sinusoids. Down the center of the tube is an artery. Okay. And think of the wall of the tube as a thick casing called the tunica albuginea. Okay. Right under the tunica albuginea are veins. We call subtunical veins. So as the blood comes in, it presses against the wall and prevents the blood from coming out. So very clever system. The more blood comes in, the muscle can then press against the wall and prevent the blood from coming out of the penile tissue. The problem is, as we age, we get atrophy of the muscle, right? And we get fibrosis of the muscle. So as we get atrophy and fibrosis of the muscle, we are able to get the blood in, but we can't keep the blood in.
Because we can't maintain enough pressure on the venous wall.
That's right. And so how do you overcome that? There's several ways. One is that you can actually, so it's a simple outflow inflow game. So if the inflow is 10 and the outflow is 15, you're not going to get an erection, right? But if you give someone Viagra and you make the inflow 25, you can overcome the venous leak by increasing the inflow. That's one way. The second way is actually some people use something called a penile band.
Like a tourniquet.
Like a tourniquet, because if you use a tourniquet, you can actually compress the veins and still allow the inflow. So if a man...
So you haven't fixed the inflow problem, but you've increased the back pressure on the outflow.
That's exactly right. So if a man took his hand while he's having an erection and placed his hand and grabbed the penis at the 5 and 7 o'clock position and put pressure, you'll notice that you'll get better and better erection because you're blocking the outflow. But you can't keep your hand...
And tell people why you said 5 and 7 o'clock.
Well, that's typically... it's circumferential.
Oh, it is.
It's circumferential.
Okay. I thought the veins were disproportionately.
It's circumferential, but if you put your hand there, it gives you almost a 180 protection.
I see. Okay.
So then so it's circumferential, but
so it's not like the fingers where at about 5 and 7
it's
we
all
have
the way
the
around.
majority
It's
of
all
our
the way around.
venous occlusion. Okay.
Yeah. So that's why if you apply a tourniquet, you actually prevent venous leak.
I see.
But most people say, I don't want to use a tourniquet. I say, that's fine. Just increase the inflow. That's why we use intracavernosal injections. We'll use Viagra. I mean, there's ways we can significantly increase the inflow to overcome the outflow. But aging does cause a venous leak. We know that lower testosterone levels have been implicated for causing venous leak because it's atrophy of the penile muscle. So when I do a lot of a procedure called a penile prosthesis, and I have a lab. So what I do is we have a protocol where we can take the tissue, the penile tissue at that time, we send it to the lab, and then we'll look at it. High density of androgen receptors within the penile tissue, right? But as the androgens go down, you can start getting atrophy of the penile muscle.
That is very interesting. And I do want to come back to the intracellular and nuclear distribution of androgen receptors, testosterone and DHT. So again, I'm trying to keep track in my mind of all the things I want to come back to. If you said to me, Peter, how can an aging person prevent atrophy of their muscle? The most obvious thing that comes to my mind is use it, right? It's a use it or lose it system.
Right.
Is the same true of the penis?
It's very true. So if you look at patients who are not using the penile muscle, for example, let's look at patients who have a radical prostatectomy. Very unfortunate. Young man, say he's 52 years old, and right after that surgery, he's not using the penile tissue. You will start getting atrophy of the muscle, just if I put your arm in a cast today, right? So regular erections, so nocturnal erections are very important also, right? So that's how we get our oxygen into the penile tissue, through the nocturnal erections, through sexual activity. There are studies suggesting that daily PD5 inhibitors, Cialis, Viagra, can help with hypertrophy of the cavernosal smooth muscle. So that's why I particularly like to give patients daily Cialis, because
even if they don't have ED?
So let's think about this for a second. I just mentioned earlier that 40% of men have ED at 40, 50% at 50. It's inevitable. It's an aging process, right, to some degree.
Yeah.
So when you take Viagra, you are not curing your ED. You're just covering it that night while the disease continues to progress. Right? But daily Cialis has been shown to cause hypertrophy of the cavernosal smooth muscle, keep the tissue healthy. So in many ways, I look at daily Cialis as a preventative measure to keep the tissue healthy. Now, I tell patients, when is the best time to start? When you start noticing if there's a mild degree of ED, something starting to show up for ED, that's when I want you to start taking the daily Cialis, not only to help you with what your issue is, but I look at, to me, as a preventative measure.
you've talked about daily Cialis. My recollection is that there were basically two dosing strategies, right? There was 20 milligrams. The idea, I think it was, hey, take 20 milligrams on Friday and it'll hold you through till Sunday, and you can basically, have sex on demand. Alternatively, it's having 5 in your system every single day produces the same tissue level. Is that directionally right?
Not close. So the conversion is 1.6 as the multiplier.
Okay.
So if you take 5 milligrams every day, it's like having almost like 8 milligrams
in your system.
In your system, 8.
Yeah, I got it.
That's the conversion is 1.6. So 8 is obviously less than 20, but some men really don't need 20.
I see.
So that 5 daily. Now remember, there's other benefits. 5 daily has been FDA approved for B.P.H. And we'll talk about, B.P.H. and ED,
know that.
FDA approved. So you can give someone Flomax, or you can give them daily Cialis.
Well, the problem with Flomax is retrograde ejaculation.
You got it. So think the young men, if they had a choice, they'll say, I'll take the Cialis, and the side effect will be better erections.
Yeah.
Right? So FDA approved for B.P.H.
Why? What's the mechanism?
So mechanism unknown, right? And that's what's a little bit interesting. So all we do know, it even says in the packet, mechanism unknown, but we do know that IPSS scores, these are urinary symptom scores, do improve in men who take daily PD5 inhibitors. That's true. So you just have to be careful not to, if you do take Cialis and a Flomax medication, not to take them too close together. There's a warning because you can get a little hypotensive.
Yeah. So
we have to separate them. But daily PD5 inhibitors are also, if the FDA approved for pulmonary hypertension. So
that I knew.
Yeah. So, and there were wonderful studies looking at daily Cialis versus on-demand Cialis, showing that the patients who took it for 4 weeks daily, significant improvement in endothelial dysfunction. And we'll talk about that later. But
endothelial dysfunction outside of the penis?
Outside of the penis.
Meaning systemically?
Systemic. And they were looking at blood markers, IL-6, C-reactive protein, not so specific. They were looking at flow-mediated vasodilation, brachial artery. And they were showing that even if the patient stopped, this was a study by Aversa, even if the patient stopped the daily Cialis versus the on-demand, those patients who took the daily still had persistent improvement. So maybe there may be something going on in the endothelium as well. So I think about endothelium, I think about pulmonary hypertension, I think about B.P.H, I think about ED, it's 5 milligrams daily, very affordable. Okay, maybe we can,
What would you say is the biggest downside of Cialis?
So I used to say cost, and it was unbelievably
How much did Cialis cost?
It was almost $15 to $20 a pill. So the history...
$15 or $20 for a 5 milligram?
Well, it was a 20 milligram pill. So, but it was still absorbent. It was like almost $400 for a 30-day supply of 5 milligrams, which was unbelievable. So then we started going to the compounding pharmacies. We said, okay, the compounding pharmacies said we can make it for $1 a pill. That's great.
But it's hard to trust the quality, right?
Some are better than others, and some compounding pharmacies are FDA approved. So that makes it a little bit better.
Yep.
But then the generics came out, and it was shocking. If I give a patient who goes to HEB, they can get 90 pills of Cialis for $17 with no insurance. 90 pills, $5.
Are you concerned? I've become very concerned with the quality of generics.
Yes.
And realizing that not all companies are the same. Like Sandoz is a good company, but some companies are.
Sure.
Do you have preferred brands of generics that you fancy?
I don't have a preferred brand, although I haven't seen the generics significantly less effective than the brand when it comes to PD5 inhibitors, right? And so, I think that's one thing that I think I have not seen it less effective.
That's great to hear. Okay. So I know this is sort of indirectly related to ED, but what about refractory period? So any guy listening to this can think back to being in his 20s where you seem to be able to, have an erection, ejaculate, and 7 minutes later have another erection.
Sure.
You could have intercourse 27 times in a day. Sure. And then something happens when you get older, those days are done, right? You might get 2 a day.
Sure.
Is that considered a lagging or leading indicator of ED? Is the fact, what's different about that 20-year-old versus the 50-year-old?
Yeah, so there's no question that the refractory period goes up as we age. One of the implications for refractory time is prolactin. So when you have an ejaculate, your orgasm, your prolactin levels go up.
Okay.
And that's been implicated as the reason for the refractory time. But as men get older, you're right, ED is more prevalent. So it's harder to get the next erection, and the refractory times go out. Right?
And I'm sorry, is there anything different about the prolactin secretion?
I've never seen a study showing that, although I would intuitively think the prolactin may be for a longer period of time, but I have not seen any study showing that.
So that might be the indication, basically, that even if you don't have ED, things are changing. Your anatomy, your physiology is changing.
Absolutely. Absolutely. And I think the majority of it is more difficult to get an erection as we get older, and therefore that contributes to the refractory time.
It's so interesting how evolution simply, you would argue that, not that we want to spend too much time speculating on evolution, given that, as Andrew Huberman would say, neither of us were there for the design phase, but it's interesting in that you can certainly understand, I think, in the case of women, why, based on the change in reproductive state, evolution didn't care as much about their sexual health as they got older. Is the same true for us, where evolution sort of thought, the older you get, the more genetic mutations in your sperm. I actually don't want you reproducing as much when you're 50 as you are when you're 20?
Yeah, I don't know about that. We have patients who are older that have great semen parameters. I think it's based on your quality of your health, right? So healthier men,
which, by the way, would make sense.
It makes sense because you're more likely to reproduce. So we look at men who are in their 80s who are in great shape. They're having sex, no issues, no even unassisted.
Meaning they don't even require. They use a bit of Viagra.
Yeah, but some do, some don't. I mean, I have patients at 70, 80 years old, great shape, no issues having erections. The patients that come to me who are older, 60, 70, who are also trying to conceive, they marry someone younger, and you'll be surprised. Typically, sometimes you will see patients with sperm spermatogenesis even at older ages. It's based on your quality of your health. I have younger patients who are 30 that are in terrible shape, poor quality erections, terrible semen parameters. So I don't know if age is the main driver.
No, I think that makes sense. And I think I talked about this with Sharon on the podcast, but I almost wonder if the greatest motivation for a patient, especially a male patient, with respect to insulin resistance is actually erectile function, because definitely one of the things I've seen in my practice is that patients who go from having a higher hemoglobin A1C to a lower hemoglobin A1C will often notice an improvement in erections.
Yes.
And again, I'm not talking about a 1-point change, but if someone goes from having a hemoglobin A1C from 5.9 to 5, which represents probably about a 25 milligram per deciliter reduction in average blood glucose, that's a person who says, I used to need Cialis for every erection, to I'm totally fine.
So you bring up a really important point. It's lifestyle modification. Lifestyle modification has a huge impact on the quality of a man's erections. And the 4 pillars that I stress all the time for most sexual dysfunctions: diet, exercise, sleep, and stress reduction. If you chose to do one of them, it would have an impact on your quality of your erections and your quality of life, right? And there's other manifestations that would improve as well. But you're talking about insulin resistance. And when you improve insulin resistance, when you improve obesity, stop smoking, all of these things improve. Now, I think there's a reason for this. There's a strong correlation between cardiovascular disease and ED.
Yep.
If I made a column of the risk factors for ED and cardiovascular disease, they're almost identical on both sides. So I say, what is the common link? Why is ED? So many studies say that if you get ED today, within 7 years, 15% of those men will have a heart attack or a stroke. 15%. It's the first sign of cardiovascular disease. Numerous studies have shown that.
And just to be clear, this is not psychogenic ED. This is
organic.
This is organic. So say that again. What percent? 15%
So
of men.
2004, Ian Thompson had the prostate cancer prevention trial. Roughly 4,000 men did not have ED, healthy men. He followed them prospectively. From the day they developed ED, 15% of them had, in 7 years, had a cardiovascular event. That's significant. And he wasn't the first. Numerous studies have shown a correlation between ED and cardiovascular disease. Yeah. Montorsi that same year showed that if you had a cardiovascular event, you had 50% of those men had ED 39 months prior to having the cardiovascular event. It is the sentinel sign of cardiovascular disease. Now, so
it's a real canary in the coal mine when it comes to microvascular health,
particularly if it's arterial insufficiency.
Yep.
So the question is, what's what's the relation? So one theory was the arterial diameter theory. And it doesn't make a lot of sense, but this is the theory. If you look at the penile arteries, they're 1 to 2 millimeters. The coronaries are 3 to 4 millimeters. The peripheral arteries are 6 to 7 millimeters. And if you get 50% occlusion of an artery, you get end organ damage. So you're more likely to occlude the penile artery before you occlude the coronary before the peripheral. So that was the theory. Now, it doesn't work very well because most of ED is a veno-occlusive disease, and really it's the pudendal artery, not the cavernosal artery, but that was one theory. The most prevailing theory is endothelial dysfunction. That is the common link between ED and cardiovascular disease. Well, the cardiologists were very clever before the urologists to show that if you improve endothelial dysfunction, you can actually reverse cardiovascular disease. So if that's the common link, as urologists, we just copy them.
Well, 2 of the 3 biggest risk factors for cardiovascular disease are taking aim at the endothelium, right? So the 3 big ones, ApoB, that's not an endothelial issue, but smoking and blood pressure are, one being a chemical, one being a mechanical disruption of the endothelium. And I suspect both blood pressure and smoking elimination would mediate ED.
For sure. Obesity, diabetes is one of them also. So this is called reversal. The best study I ever saw was Esposito, 2004 in JAMA. She just simply said, I'm going to give you a diet and exercise program. 110 obese men, 55 went on a diet and exercise program, 55 went on nothing, okay? And she followed them for 2 years prospectively. If you simply had diet and exercise, you lost weight. It was a Mediterranean diet, by the way. I really believe in the Mediterranean diet. If you lost weight and took the Mediterranean diet, you saw a 3-point, which was significant, increase on the IIEF score.
This is on that 6-point scale?
On the 6 questions after 25, but a 3-point. And so, on the IIEF with no Viagra, no intervention except diet and exercise.
And does that 3-point increase translate to a clinical meaningful improvement?
Close, because usually it's 4, so it's pretty close. And the meaningful improvement is broken down into, think of this as 2, 5, and 7. If you have mild ED, you want to see at least 2, moderate ED 5, and severe ED 7. So
it depends where they started.
It's where they started, right? But typically you want to see about a 4. But even just a 3, just on diet and exercise alone, they saw improvements in endothelial function in terms of IL-6. They lost weight. I mean, just diet and exercise alone reversed or had an improvement in ED. So lifestyle modification is very important when we talk about sexual dysfunction.
So let's go back to what you were saying in the office, some of the diagnostic tests. So a guy comes in, you quickly, or maybe not quickly, but you rule out psychogenic ED, and now you're realizing this is something physiologic. So you mentioned a diagnostic ultrasound. So you're doing an ultrasound of the penis. You inject something into the penis to induce an erection?
Yes. So we typically inject Trimix, which is a medication that's compounded. You can actually also inject alprazolam, which is commercially available, like Edex.
And you're injecting this into the corpus?
Into the corpora, and it will cause a vasodilation. Right.
And just because every guy listening to this is freaking out saying that you're sticking a needle in my penis.
Right. But you'd be surprised.
Not in the urethra.
Not in the urethra. At the base of the penis. We inject it at the 2 or 10 o'clock position. And within 5 to 10 minutes, it induces a very good erection. But what we're able to do with that is we're able to look at something called the peak systolic velocity. If the peak systolic velocity is less than 30, particularly if it's less than 25 milliliters per second, he has arterial insufficiency. Now, that's important. That means not enough blood flow is coming into the penile tissue. If the end diastolic velocity is greater than 5 millimeters per second, then he has venous leak. So that's important. So I can now see if there's a hemodynamic problem going on in the penile tissue.
And just so folks understand this, right? Diastole, or let's start with systole. Systole is what's happening when the heart is contracting. So you think about that as the flow out. Diastole is when the heart is relaxing and itself it's filling. And so you're measuring kind of backflow through the venous system.
Right. And that venous leak is important because remember, that's the number one cause.
Half the problem.
The majority of the patients who have ED will start out with venous leak. So, but then there's
just to be clear, the venous leak is usually happening before you see arterial insufficiency.
In most cases.
Yep.